Hello everyone, good morning from Jakarta. So hello to you from everywhere everywhere you are now. So very warm welcome from today's session on about amphetamine-type stimulant and stimulant use disorder. And thank you for joining us. I'm Christiana Sister from ISSUP Indonesia, the International Society of Substance Use Professional. And while we are waiting for a few more to join us, I will begin by saying a little about ISSUP. ISSUP is a membership organization with over 20,000 members worldwide working in the field of substance use prevention, treatment, and also recovery care. And also, if you have not done so already, please head over to our website, issup.net, and where you will find information how to sign up for free membership. Our website also has a wealth of resources and publication for you to enjoy. You can also watch recording of past webinar and see future event listing. I would like to thank the ISSUP staff for providing technical support for this event. So today we journey into the topic about amphetamine-type stimulant and stimulant use disorder with two very wonderful speakers. Is Dr. Thomas Ifris, and PhD, and he is director of UCLA Integrated Substance Abuse Program and also co-director of Pacific Southwest Addiction Technology Transfer Center, HHS Region 9. And also, he's also the expert from amphetamine-type stimulant treatment center, and he will present about amphetamine-type stimulant and stimulant use disorder. And he will present about amphetamine-type stimulant, and he will explain more about it. And you can also ask everything to him. And please do your question in chat box, and I will ask Thomas about your question. And you will have the opportunity to submit a text question to our presenter by typing your question into the question panel of the webinar interface on your screen. And you may send in your question at any time during the presentation. We will collect this and address them during the question and answer session at the end of the two-day presentation. Webinar online event delivered and hosted by the International Society of Substance Use Professional, or ISSUP, are provided for informational purpose only. They are educational in nature and do not constitute medical advice, diagnosis, or treatment. A recording of the webinar will be made available for you to watch on demand after the event. We hope you will stay with us for what promised to be illuminating session. You will take away from this, if nothing else, as much more informed perspective of this topic. And now, it is my pleasure to hand over to our guest, Dr. Thomas Ifris. So without further ado, the time is yours.
Thank you very much, and Dr. Christian. And you can see my slides okay? I assume we're good. So thank you.
We cannot hear your voice very well. Detania, you can hear Thomas' voice well?
We're okay?
Yes.
Okay, perfect. Hello, everyone, and I'm very happy to be here this evening for me, for morning for many of you. As we polled the organizers and the speakers, we truly represent the entire world, as I'm sure you do as well. I'm happy to talk with you today about amphetamine-type stimulants and stimulant use disorder. And what I'll do is I'll talk a little bit about the problem globally, focusing on some specific data issues that we've learned from the United States, but I think apply globally in very important ways. We'll then talk about the impact of stimulants when you use them and how they work inside the body. That'll take us to the end of my presentation, and then I'll turn it over to Dr. Ediwanti for more on the pharmacology and psychiatric consequences of the drug. So looking a little bit at the scope of the problem, amphetamine-type stimulants are the third most widely used illicit drug category in the world, following cannabis and opioids. Now, these numbers are a little bit misleading because what's not counted in here are substances that are considered legal in many places of the world, alcohol and tobacco, which outstrip all of these categories in terms of the number of people that use. But illicit drugs, amphetamine-type stimulants are number 3. What kind of stimulants are being used depends on where you are in the world. In Europe and the Middle East, it tends to be more short-acting amphetamines. They last for about 4 to 6 hours on average. In the US, in Australia, and in Southeast Asia, use tends to focus much more on methamphetamine, which is the longer-acting version of the drug. And we'll talk more about that as we go along. The manufacturing methods differ around the world, but once you come out with a product, it may be more pure or less pure, but amphetamines are amphetamines and are amphetamines, and they're going to work in exactly the same way. So this is the data that I presented in a slightly different way. Now, this data reported specifically from the United States, and you see alcohol and tobacco are number 1, with cannabis being number 3, and the other ones following downward from there. I present these data just by way of context, but some of what we learn from these data I think are really important from a worldwide global perspective. First of all, the purity that we're seeing in the United States and in other places that I've been able to find data around the world has significantly grown in the last couple of decades. In the early 2000s, we were seeing methamphetamine purities in about the 30 to 60% range. But amphetamine that is being consumed on the streets today is upwards of 95, 96% pure methamphetamine. It is a more pure drug, therefore a more powerful drug, and we think that some of the increased consequences that we see from use may be in part due to this purity of the drug that's available now. One of those consequences is overdose. And in the United States, the overdose death rates or drug poisoning rates are driven primarily by the use of fentanyl, an illicit synthetic opioid. But second in line are stimulants. And while that combines both cocaine and methamphetamine, we see numbers that are approaching the same numbers that we see from synthetic opioid overdoses. The focus in many places on overdose deaths has been on providing medicines and controlling the use of fentanyl. But this slide begins to demonstrate for us that if we don't address the rapidly increasing rate of stimulant use, we're never really going to be able to impact the number of people who are dying from drugs. The way you look at that point, this shows data across time from 2010 to 2021 on the far right-hand side. And the way this slide reads is on the bottom, you see about 1/3 of people who died from drug poisonings died from exposure to fentanyl only. Another third died from exposure to both fentanyl and stimulants. And again, they don't separate out methamphetamine from cocaine in this regard. The next group, 18%, almost 1 in 5, died from stimulants only, with about 16% having neither fentanyl nor stimulants on board at the time. So if you add up these numbers, the red bar and the purple bar there, we see that about 50% of people who died from drug poisonings died from either stimulants by themselves or stimulants in combination with fentanyl. That tells us that we have to have those medicines for opioid use disorder to be able to prevent and reduce overdose, but that in and of itself is not going to help us completely solve the problem. Where you live also matters. And again, this is data from the United States, so we don't know how well it translates to other parts of the world. But as I do work on the Pacific Islands and elsewhere, this data becomes really important because of how rural so many of those places are. If you look at urban areas in the United States, that green bar that's way out in front and that top group there is fentanyl, synthetic opioids, and it really is the leading cause in urban areas of drug poisonings. But this bottom group of bars shows much more diversity in terms of what people are being exposed to and that are causing death in those rural environments. So certainly still fentanyl is driving many of the deaths, but then we see that methamphetamine is the #2 cause, and again, approaching the rate of methamphetamine in terms of causing death in those areas. So that always causes me concern, and I always ask, what is the methamphetamine issue looks like, particularly in areas that are highly rural, because I think the risk of exposure is much more significant. And this is actually a block of methamphetamine that was found floating in it washed up on shore in the Marshall Islands, I believe it was. And this is from shipping across the ocean, and either the boat capsizing or them throwing their drug contraband overboard because they were at risk of being caught by authorities. But ultimately what ends up happening is places that are even not exposed necessarily to, or not on the shipping routes necessarily for drug distribution, are getting increasing exposure from just the transfer of these substances across the Pacific. So I don't want to take up too much time with data, but I did want to show a little bit so that I could demonstrate that this really is a significant problem, and it has serious and potentially deadly consequences for people who are using. So let's talk a little bit about what it does when we put it inside the body. This is a cartoon of the brain, and it shows all of the areas of the brain that are impacted by psychoactive substance use. So anything that makes you high is impacting these areas. These areas on the outside of the brain are largely about the experience of the brain, so of the drug. So it affects movement, and you may have more energy, or you may get kind of staggery. It affects the way you feel things, the way you see things, maybe sometimes coordination and movement. But when we talk about the development of addiction, we're talking about these areas deeper in the center of the brain, primarily the limbic reward system, the prefrontal cortex where we make decisions, and some memory circuitry that sort of combines all of those things together. And as we deal with methamphetamine in particular, what we see is a powerful stimulation of this reward system that is unlike anything else that we can get. Now, anything that feels good is going to stimulate the dopamine reward system. So these are some animal studies that were done, and they measured the dopamine output in rat brains. And they found that in the pleasure center of the brain at rest, there were about 100 units of dopamine. They let a hungry rat eat something, and you see an increase in dopamine from about 100 units up to about 150 units, and then tapering off from there. The experience from the rat, I was hungry, it feels good to eat. In another way, if you look at sexual behavior, again at baseline, we see the rat at 100 units, and you let rats come together and engage in sex, and at the point of orgasm, you see a spike from 100 up to 200, even more powerful than we see with food. So this is actually the biggest spike that we can get from natural phenomenon in terms of the overall experience of pleasure. But when we start adding other illicit substances on board, we play with those mechanisms in really powerful way. This first one up here is alcohol, and you see that it has a rate of dopamine response at about the same level as the sex response, that pink line right there. Nicotine, for those who smoke, again, about the same level as the sex response. That's often why with these substances, we begin to see a pairing of the sexual behavior or other pleasurable behaviors with consumption of alcohol or nicotine, because not only do each of them feel good by themselves, but they add to each other, and you get a cumulative effect of the two. Now with cocaine, we see an even bigger spike. This is the sex response here, and we see a spike up above 300 here. So this is an experience of pleasure that is really powerful and overwhelming and highly reinforcing. Now we have to change the scale again when we talk about methamphetamine. The sex response is here, cocaine is about here, and methamphetamine is way up here at like 1300. There is nothing from a neurochemical or a natural phenomenon that can equate the kind of pleasurable response you get from use of methamphetamine. So why do people use stimulants? They use them because they feel really good. In fact, when I saw these data for the first time, I thought, why didn't I use them before I knew anything about them? Because that looks really amazing. Well, it's really good that I didn't, because what happens is it begins to change the brain from your first administration. And each time you use, you're impacting the brain and the way it functions more and more, such that you get a great reduction in the amount of dopamine, those pleasurable chemicals that are available to people as they use and then as they stop using. These three pictures are pictures of brain scans, PET scans specifically, that look at those pleasure centers of the brain. And those funky fish-shaped looking things in the middle of the brain, those are the pleasure centers of a human brain. And these are three different brains. First of all, a brain that is not exposed to methamphetamine. The more red you see, the more activity. So the closer to red and yellow, the more activity you see. And this is normal functioning for a person given a controlled situation. With someone who is just withdrawn from methamphetamine, we see many more greens and blues, much less red and yellow, and therefore we're noting that there's a great reduction in the amount of dopamine that's available in this area of the brain. The third brain here is a disease that works in the same area of the brain, on the dopamine system. It works quite differently, but that's Parkinson's disease. And we used to think we would see brains that looked more similar to Parkinson's disease than a normal control. And that's what resulted in the twitchy, kind of Parkinsonian-like symptoms that you see with significant methamphetamine use. But no one at the time thought that it was directly related to Parkinson's. But now there are studies that have been going on across from 2010 and beyond that indicate that not only do those brains look more similar, but there's actually an increased risk of developing Parkinson's for people who have used methamphetamine, from 75% more likely in the first study in 2011 to 300% more likely in the second study in 2015, showing that if you use, you're more likely later in life to develop Parkinson's, and that's true even if you stop using the drugs. It's also noted that in the 2018 study that this may be the thing that puts the person at risk directly for Parkinson's disease. So we don't often think of diseases like Parkinson's as directly related to substance use, but these data show that we're impacting the brain in a variety of different ways that can actually increase the risk for and the vulnerability to some of these other seemingly unrelated disorders. Now, what happens when we consume amphetamines? First of all, it feels just like excitement. You get increased heart rate and blood pressure, your pupil size constricts to focus your vision, you get increased respiration, which actually gives you more energy, and you get increased sensory acuity, or your senses become more sensitive. On the other side, it decreases your appetite, so you don't need to eat as much and you might lose some weight. It decreases your need for sleep so that you can get more done and be active for longer. And while it decreases your reaction time, you feel so great about everything else, you're probably not even going to notice that. From a psychological perspective, it increases confidence, alertness, your mood is through the roof, your energy and talkativeness are fantastic, and you can literally have sex for days, which is why people often associate stimulant use with sexual behavior as well. On the flip side, if you're a shy, lonely, timid person, all of those things go away in the face of methamphetamine. So suddenly The shy person who can't interact with people at a party can step out, dance, and become the life of the party in that way. So again, early on, it feels pretty good and it works pretty good to get some of the things that we want. But after using for a really long time, we begin to see that excitement sustained for too long begins to take on a really ugly kind of anxiety kind of edge. I'm going to focus more on the left-hand side of this chart right now because Dr. Inamati is going to focus on the psychological impacts in her presentation. But you begin to see some of the consequences of use, including tremor and weakness, severe weight loss, infections and sinus infections, significant dental problems, complications of use like burned lips, sore nose, etc., headaches, diarrhea, anorexia, and overheating. And in fact, if you look across the organ systems, we see that methamphetamine is not good for any of them. It causes significant respiratory problems, significant neurologic problems like stroke, seizure, and cerebral hemorrhages, causes kidney and liver problems, and it causes all kinds of cardiac problems, including problems with the rhythms of the heart. In fact, when people die from overdose, they very often and most commonly die either from cardiac implications or from neurologic implications that ultimately are what lead to their death. And then as we'll talk about later, we see psychological effects that are significant as well. Two more things to note. Which is significant skin problems, sores that are over the course of the skin. These are due to a number of things. One, maybe just less overall hygiene as a result of going long periods of using and not thinking to bathe. There's an increase in sweating, which can cause some skin problems. But there's also a psychological process called formication, which is the experience of bugs or electricity crawling under your skin. And if you have bugs under your skin, you want to get them out, and so you pick at them. And so people will come in with peripheral signs of sores on their extremities in particular, where they're trying to get those bugs out. They will explain them away in a variety of different things like scabies or rashes or things like that. So watching for those kinds of bumps with some of the other symptoms may be one of the first things you notice in a patient that's been using methamphetamine. The other thing that we see is significant impact on the teeth. And there's been quite a few studies that have looked at why the teeth are so at risk. And I think there's a number of different reasons. The drug itself is acidic, and you're passing those acids over your mouth, which may make it a hostile place for your gums and teeth. There's a drug-induced craving for sugary substances, and so you may suck on lots of candies or things like that. It's been noted that people will drink less water during the time that they're on amphetamine, leading to dehydration. Dehydration causes dryness in the mouth, which also increases the acidity of the mouth. And it's really hard when you're going on a party or having sex or doing work for 2, 3, 4 days to always remember to stop and do good oral hygiene. And so a lot of this may be just a result of bad oral hygiene. One final problem is that it causes a condition called bruxism, which is a clenching or grinding of the teeth. And when you clench or grind your teeth together too much, even really good teeth, I do this, by the way, I have to wear a guard at night so I don't clench my teeth too much because my teeth crack just from the pressure that I put on them from my jaw. And as people use methamphetamine, they do that on an ongoing basis throughout the day and can cause damage to their teeth in that way. Bad teeth really hurt. And so if someone doesn't get help for those, it's a significant indicator of relapse. And because sometimes their teeth are so ugly, it's socially unacceptable often to show them your teeth, so they'll work to hide them. So unless you particularly notice or you ask them about the quality of their teeth, they may not tell you that information. And then finally, there are significant complications during pregnancy. You see the list of complications here. This is true of both cocaine and methamphetamine, migraines and seizures, premature ruptures of the placental and uterine lining, increased blood pressure for both the mother and the developing fetus, swelling and seizures, spontaneous miscarriage, early term birth and difficulty in delivery. And we know that one of the biggest risk factors for babies, in addition to all the things that happen in utero, is being born young also places them at risk for a variety of ongoing issues. Methamphetamine also seems to be associated with cardiac and brain anomalies in the newborn and neurologic problems as indicated by decreased arousal, increased stress response, and attentional impairments at the time of birth. So getting people into treatment and care while they're pregnant and keeping them engaged in care becomes really important. One of the last things that people are really concerned about is the increased association with methamphetamine use and violence. And it is true, according to the studies, that there's about a twofold increase in the expression of hostility or violence among people who use methamphetamine. In my experience, having treated hundreds of methamphetamine users across the course of my career, is as long as you engage in good kind of de-escalation techniques in your interaction with them, for the most part, it doesn't enter our clinical environments. But this association with violence happens in their world on the outside. And so very often methamphetamine users, particularly women, are the victims of abuse or violent act. Engaging with those people and doing assessments for trauma and providing good trauma-informed care for those individuals who have been exposed is really critical in engaging them and keeping them engaged in care. The good news is the brain does heal. These are the same two brains I showed you before, the non-exposed person, the exposed person. These two brains over here are the same person 24 months apart after not using. And this brain is not statistically different in terms of the dopamine output that you get from the control brain, meaning the brain heals. It doesn't mean that they won't have ongoing symptoms, but it does mean they'll be functioning much closer to normal than they were prior to during their methamphetamine use. In terms of treatment, behavioral treatments are okay, although they have much less impact on methamphetamine than what we see with other kinds of substance use disorders. The best single treatment that we have is contingency management, which is providing reinforcers for not using substances primarily. You can also add in community reinforcement approach, which works with the person's environment to make not using drugs more reinforcing than using drugs. So it's also an incentive kind of protocol along the way. Those two together have been shown to be, individually and together, have been shown to be the best treatment approaches that we can have for methamphetamine. Combined with those, or in the absence of those, we also know that we get some effect from cognitive behavioral therapy and motivational interviewing. Structured cognitive behavioral therapy, like the matrix model, is preferred to more kind of loose and open cognitive behavioral therapy. Mindfulness seems to have some impact on reducing depression and anxiety symptoms, which can help hold people in treatment better. And exercise by itself has been shown to lead to a reduction in methamphetamine use, and even more than that, a bigger reduction in anxiety and depressive symptoms. So I think adding exercise into anything else you do is highly recommended. So I put in some evidence that I'm not going to go over with you right now related to the studies that have been done. I summarized all of those in those environments. What I want to leave you with before I stop and turn it over to our next presenter is some things to think about in terms of the way that people who use methamphetamine function. Their ability to reason and process and their processing speed is significantly slowed, in part because of the dopamine issue, but also other issues that happen inside of the brain. And so as we provide treatment to them, if we do treatment like we do with people who are functioning in more normal ways, we're going to have much less of an impact. And there's been some work being done on working with people with cognitive impairments that's begun to be applied with methamphetamine user and seems to show some promising results in clinical experience. So rather than doing hour-long sessions, for instance, think of doing more shorter sessions. And if you're stuck in a system where you have to do an hour-long session, for instance, think of it as 4 15-minute sessions, where you work for 10 minutes and then take a 5-minute distraction break to play a game, walk around, use the restroom, get a drink, and then do another 15-minute session, and then another 15 minutes. So shorter, more frequent sessions are better. We want to repeat information as much as possible and give them information and content in as many different ways as we can: audio, visual, experiential, verbal, all of it, play games with them, any way that we can think to present the information in multiple ways. So we're using more of the brain to create those memories and help them hold on to that information. Doing stress management and breathing, mindfulness, etc., can be very helpful. Putting things in writing so that they can refer back to it if they don't remember is really important. And at the end of my presentation, which I believe will be shared with you, there are a number of resources that go deeper into this particular content and that are all available free of charge to you. This is a series of educational tools, 17 5-minute little segments on stimulants specifically that can be really useful for you, each of you as a clinician, but also useful in educating your the clients that you work with. Number of other resources that are available along the way. And with that, I will stop and turn it over to our next presenter.
Okay, Thomas. So thank you so much for the wonderful presentation. So you explained very much about the about the effect of methamphetamine and amphetamine in the brain, including about cognitive decline. So it's very interesting, and we will ask the question at the end of the session. So we will go through the second. Yeah, thank you, Thomas. So we will go to the second presenters. She is from Indonesia, Dr. Erniawati Lestari, and she is clinical pharmacology. And now she is clinical pharmacology and health administrator, Directorate of Strengthening Community Rehabilitation Institution, Deputy for Rehabilitation in National Narcotic Board of Indonesia. And she has many research about methamphetamine in her institution. And now she will present about pharmacology profile of methamphetamine and its association with psychiatric symptoms in methamphetamine use disorder. So without further ado, the time is yours, Dr. Erniawati.
Thank you, Dr. Sister, for providing me a time, and hello all participants ISSUP Stimulant webinar. I think I will try to share my presentation first. Okay. It is see, Dr. Sister?
Yes, we can see your slide.
Okay, thank you, Dr. Sister. Today I will presentation about pharmacology profile of methamphetamine and its association with psychiatric symptoms in methamphetamine use disorder. So we will talk about stimulant, how the condition stimulant in Indonesia, and then we will talk about profiling. Sorry. Profiling of methamphetamine in Indonesia, and then we talk about pharmacology methamphetamine, and then we also talk about methamphetamine use disorder and psychiatric disorder, and then the end of the presentation we talk about important point. So for the first, we see about the situation of the stimulant use in Indonesia. Okay, drugs use disorder continue to increase years by years. As we see in the presentation, the prevalence rate of drug use in the past 12 months is increased 0.50%. It's in 2019 to 2021. In the same period also, the prevalence rate of drug abuse of every use is increased 0.70%. In Indonesia, amphetamine-type stimulant is the second most consumed drug after marijuana at 41.4% and followed by methamphetamine at 25.7%. People with methamphetamine use disorder was found to be female were quite dominant compared to male. it's 56.9% and SIP 34.9%. And then we will talk about profiling of methamphetamine in Indonesia. The National Narcotic Board of Indonesia, especially a laboratory center of National Narcotic Board of Indonesia, is sorry, I can see the slide. Do the profiling methamphetamine in Indonesia. We found type crystal isomer of methamphetamine, first dextromethamphetamine and then levomethamphetamine or racemic. And then we also find suspected precursor type and precursor source, which is from natural, semi-synthetic, and synthetic. And we also provide profile of precursor used in the synthesis of methamphetamine in Indonesia. We can see from the data from 2019 to 2022, ephedrine was the most widely used type of precursor in the manufacturing of methamphetamine. However, in 2023, there was an increase in case with the use of mixture. So it is both ephedrine and P2P or penyl 2-propanol in the manufacture of methamphetamine in 2023. And if we see about the purity of methamphetamine in 2019 and 2023 in Indonesia, the average level of methamphetamine purity each year from 2019 to 2023, we can see in the presentation is about 90%. In 2019, we can see 95.80%, and then to 2020 is 96.35%, but in 2021, this is the we find the average level of lower methamphetamine purity. It's about 89.70%. So we talk about the pharmacology of methamphetamine. Amphetamine-type stimulant or ITTC have a methyl group on one of the carbon arms of phenylethylamine. Okay, we can see this one is the chemical structure of methamphetamine and amphetamine, with both is quite similar, both having a methyl group which is attached to one of the carbon arms of phenylethylamine. Can see here, phenylethylamine. The difference lies in the additional methyl. So methamphetamine has additional methyl group attached to the amine group. This causes methamphetamine is very fat soluble, so that it is easy penetrate the brain barrier. Methamphetamine pharmaceutical found by crystal and then powder, tablet, and liquid. Methamphetamine also observed is related to route of administration, which is oral or intranasal, smoke or intravenous. And then the distribution of throughout the body, especially to the kidney, lung, liver, pancreas, heart, and especially in the brain, because as I mentioned before, that the methamphetamine is very fat soluble, so it can into the brain very easily, and then metabolized by CYP. Sorry, I have to by CYP 2D6 plasma half-life 10 hours, and then we also have to know about excretion through the urine is about 70%. In the form of 30 until 50% methamphetamine, and then 50% in the form of 4-hydromethamphetamine, and about 10% it form amphetamine with an excretion half-life of about 25 hours. We can see the differences about the bioavailability, the route of administration of methamphetamine, and the dose of methamphetamine. This is, we can see by route administration by intravena is very high bioavailability, is almost 100%, and time to peak effect is about less than 50 minutes. If we route the administration from methamphetamine we smoke by 30 milligram in dose, is bioavailability average 90%, and the time to peak effect is 80 minutes. If we route administration by oral with dose 30 milligram, it is can achieve bioavailability in 6-7%, and time to peak effect is 180 minutes. And if we do by nasal, the dose with 50 milligram, bioavailability will take a 79%, and its time to effect less than 50 minutes. So methamphetamine, also known as N-methylamphetamine or dextroephedrine, is class of amphetamine-type stimulant. Methamphetamine has two stereoisomers, namely D-methamphetamine, which is 3-5 times stronger in activity against the central nervous system compared to E-methamphetamine. Both stereoisomers affect the release of monoamine neurotransmitter, namely dopamine, norepinephrine, and methamphetamine is indirectly acting symptomatic amine. It's release dopamine. It will see the presentation chart, met-regulated dopamine. Methamphetamine, that I say before, is an indirectly acting symptomatic amine. It release dopamine, serotonin, noradrenaline, and adrenaline from nerve terminal, thus increasing their neurotransmission. As a result of its high lipophilicity, methamphetamine easily cross the blood-brain barrier. Because its chemical structure is similar to the monoamine, methamphetamine is recognized as a substrate by dopamine, serotonin, and the noradrenaline plasma membrane transporter in the brain and transporter into neuron and neuron terminal. Methamphetamine also cross the neural membrane by passive diffusion. Once in the neurotransmitter, methamphetamine acts the monoamine strong physical and deepest jump of the neurotransmitter. In addition, methamphetamine inhibit monoamine metabolism by inhibit of monoamine oxidase. Consequently, intracellular level of cytoplasmic dopamine and other monoamine are increased. So we can see the normal neuron and then neuron, that we can see the dopamine level is very increased. In the chart, we can see the dopamine very increased, and then after dopamine quickly increase, and dopamine also auto-oxidized in the cytoplasmic and generate reactive oxygen species, ROS, or reactive oxygen species, leading to the generation of dopaminergic terminal in most species. Methamphetamine also inhibit and trigger reversal of the monoamine transporter, which result in a massive release of monoamine into the synaptic cell. So it's the next result of the action of methamphetamine is overstimulation of the monoaminergic pathway in the central and peripheral nervous system. We found higher doses trigger an increase in glutamate in the striatum, which result in exocytosis. So neurotoxicity and exocytosis neuron caused by methamphetamine. After that, methamphetamine interact with presynaptic dopamine receptor by competitive antagonist and has minimal effect an antagonist at postsynaptic dopamine receptor, but activity the indirect by released dopamine. In addition to the damaged dopaminergic and serotoninergic terminal, methamphetamine damage neuron in some brain area that we'll see in the frontal cortex and hippocampus, and then the cell death and damage to dopamine nerve terminal is in striatum area. And then we can see also the molecular mechanism, how methamphetamine do anxiety, dysphoria, how much dose in the more than 30 milligram. Methamphetamine can make the anxiety and dysphoria because this is increased adrenergic alpha receptor stimulation in the prefrontal cortex. And elevated body temperature is also if the methamphetamine drug use consume more than 30 milligram, because it is increased dopamine, serotonin, and noradrenaline release in the hypothalamus, and it will be talkative. This dose is more than 50 milligram because molecular mechanism is activation of anterior cingulate cortex and ventral striatum. It's also hallucination, especially auditory hallucination. So it's methamphetamine is a hallucination auditory. It's if the methamphetamine drug user is take the dose if more than 55 milligram, because this is increased activation of thalamus and ventral striatum if for hallucination auditory, but for visual it is increased activation of paralimbic and primary motor cortex. Stereotype, it's the symptom can found in the very high dose, and dyskinesia also choreotherosis is in the high dose. And then we will talk about methamphetamine use disorder and psychiatric disorder. Okay, the research is in Indonesia. This is my colleague Rohmanika in the Clinical Pharmacology University of Indonesia, and I also do this research in the pattern of methamphetamine use and its association with psychiatry symptom in patient upon admission at the National Rehabilitation Center Lido in Bogor. It's also in Center National Rehabilitation for National Narcotic Board of Indonesia. There are 1,842 methamphetamine use disorder in the subject, and then we found 770, which means is 41.8% of methamphetamine use disorder assessed with psychiatric symptom according to Addiction Severity Index. Psychiatric symptoms are health problem that often occur as a result of methamphetamine abuse, and in this research is the most symptom that we can find is a depression. Depression was the most prevalent psychiatric symptom. It is about 31.90%. After depression, we found anxiety and then psychosis. Psychiatric symptoms we can find in the subject female, duration more than 5 years, duration using meth, and then smoking route of administration, and use with other narcotic are more at risk for psychiatric symptom in methamphetamine use disorder. we can see if the psychosis in the subject is a duration more than 5 years, and then smoking and co-administration with opiate are more likely to lead to psychosis in methamphetamine use disorder. Also anxiety also this is significant in female. Those more than 0.2 grams. Smoking and use with other narcotic are more at risk at causing anxiety in methamphetamine use disorder. And depression also we find in female, duration more than 5 years, route of administration by smoking, co-use of other narcotic, other amphetamine-type stimulant and tranquilizer are more likely to cause depression in methamphetamine use disorder. So the key point or important point on this presentation, we can say that, also the higher prevalence of methamphetamine use disorder and the high level of methamphetamine purity in Indonesia. We find also methamphetamine use disorder caused by brain damage, and then the association between psychiatric symptom and gender, duration, dose, route of administration, and use of other drugs suggests that early assessment of psychiatric symptom and comprehensive management of methamphetamine use disorder is very required. I think that's all my presentation. Thank you, Dr. Sister. Thank you all participants in webinar Amphetamine-type stimulant ISSUP series. Thank you.
Yeah, thank you, Dr. Nia, for the wonderful presentation. So you explained very much about the correlation between methamphetamine and also psychiatric symptom, and you found that depression and psychotic and anxiety are the most psychiatric symptom that we can find out in the person who use methamphetamine. Depends on the dose and duration and also the gender. So now we will have a question for to our wonderful presenter, Thomas and Nia. So the first question is for Thomas. There are many questions for the two presenters. So the first question for Thomas, is contingency management also effective for methamphetamine users in residential or inpatient program?
For that question. Contingency management in the research has mostly been studied for abstinence from substance use in outpatient settings, because in residential settings, it tends to be a closed setting where access to substance use is controlled in a much more direct way. And so the intervention doesn't have the power to work in that particular context, because we need them to be able to show that they're not using and getting rewarded and reinforced for that. There are some studies, although the impact is less, that looks at things like treatment attendance and some other treatment-related goals that have been shown to be somewhat effective and can actually change the behavior immediately. But when we use contingency management for those purposes, it tends not to roll out into the rest of people's lives. Whereas when we use it for drug abstinence specifically, we tend to get a lowered rate of use that goes on for an extended period of time.
So what do you think the most effectiveness treatment modality in the residential for methamphetamine user?
I think in residential, we need to look at a combination of cognitive behavioral therapy, exercise, and motivational interviewing and mindfulness. So teaching the person to think and behave differently while they're in a controlled environment, I think is really critical. As they move out into the outpatient setting, it's much more important that we engage in behavioral management, like contingency management, to try to keep them moving in the right direction when the situation is less controlled.
Yes, and you also mentioned about the cognitive decline in methamphetamine user, and it's very important to recognize the cognitive decline, because you also should include the treatment about cognitive decline.
Yeah, yeah. We want to change the way we do treatment to make everything very short, present information in multiple ways, and present information the same over and over and over again, so that we can help them hold on to that information. And if it's really important, we have to write it down, because I can't remember, and I have a pretty good functioning brain. When your brain is damaged in this particular way, it's even more challenging for them to hold on to even the most basic information. So we want to give them a chance to look at that again.
Yeah, thank you, Thomas. Thank you so much. And the second question is for Nia. So there are two questions. How long use of methamphetamine can cause the effect, the duration, and also the dosage? And how long will the methamphetamine substance stay on the human body?
Okay, thank you for the question, Dr. Sister. For the duration effect, as I mentioned before, it's depend on the route of administration. It is if we use intravena, we can less than 50 minutes the effect will see, but so on. We can see maybe we can see the presentation again.
Yeah.
So, and the, but I can share. Okay. So my screen. Okay. So we can see the effect of the methamphetamine is depend on how the methamphetamine drugs use consume or route of administration. Intravena will time to peak effect because the bioavailability is very high, so we can find the effect less than 50 minutes. And then if we do by smoke in the 30 milligram dose, we can find the peak effect. It's about 80 minutes, and then if we do by oral, it's very long, 100, and it's almost 1 hour and 1/2 hours or 2 hours, 2 hours or more if we do by oral. And by nasal, we can find the effect less than 50 minutes. And the second question is how long methamphetamine in our body. So methamphetamine, if we see the half-life of excretion, it's about 3 days in urine excretion, which is we can see also the form is methamphetamine as 10% as amphetamine in the form of amphetamine is also I mentioned before in my presentation. I think that's all, Dr. Sister.
Yeah, thank you, Nia. And then Thomas, there is one question. Is there any similarity between the effect of methamphetamine or amphetamine and fentanyl? Thomas, can you hear the question? Are there any similarities?
Yeah, you cut out a little bit. Can you repeat it for me?
Are there any similarities between the effect of methamphetamine or amphetamine with fentanyl?
Yeah, when we use in combination with fentanyl, we get an additive effect that makes it dangerous for both drugs, increasing overdose risk overall. What I mean by that is because fentanyl is a depressant, if we add stimulants on board, we may mask the depressant quality of the stimulant and not realize how close to stopping breathing we are. And therefore, we may not risk we may not see the danger of overdose in that particular case. Likewise, if we're using the stimulant, it's an excitatory drug. and it amps up our whole system, increasing risk of heart attack and stroke, as I said before. Because of the fentanyl use, we can dampen those effects on the stimulant side, and again, mask the risk associated with how intoxicated the individual is because of these two drugs working in combination. So each of them independently has the potential for causing a drug poisoning. But when we use them together, we can get an increased risk of drug poisoning on either the fentanyl side or the stimulant side over what we see in the drug when it's only used by itself.
Okay, yeah. Thank you, Thomas. And
so
then
one more thing on that, if I could, in terms of treatment, if someone's using opioids, we want to get them good medication-assisted treatment. We want to get them on medicines as quickly as possible to manage that, but that's not going to manage the stimulant side. So we need to think about behavioral interventions like contingency management and or cognitive behavioral therapy interventions on that side, so that we're taking care of their use of both substances at the same time. Thank you.
Okay, yeah. Not just medication, but also non-medication or non-pharmacological treatment, right?
Exactly.
And then how about human genes? Because there is a question. So what's the effect of amphetamine and methamphetamine to human genes? Can you explain about that, Thomas?
To human genes? Yeah, I don't know. I don't think we know. Maybe Dr. Enyawati has more information on that. But I think at this point we don't really know what the impact is on the genetics, and it's clear that substance use runs in family. We see genetic trends in a variety of different substances, but to my knowledge, we haven't unwound the genome enough to really be able to speak specifically to many of the genetic impacts of many of these substances. Dr. Enyawati, do you have more to say on that?
Dr. Enyawati, you are muted. You are muted.
Thank you. I think there are a few research about how the methamphetamine control the gene. What it's called? I think this is the effect of the methamphetamine in the genes. Is I think there are a few research, but if we are use methamphetamine, we are also like another drugs. There are 50% for it's down by the the children or but I don't know how is also how it's impact. I think it is. I have to read also.
I think we will know,
Dr.
but I think we're too early in the research to really be able to answer that question from a research perspective.
Yeah, because because there are no many research about the gene and methamphetamine until now, and maybe we can do the research together as collaboration in the future. So yeah.
I'm ready.
Very interesting.
Yeah, because Thomas, you mentioned about the impulsivity and violence among people using methamphetamine, and I think it's also involved the gene beside involve the brain, also the gene involved in that behavior.
As we understand more about genetics, that's undoubtedly true. We just can't speak specifically to how that works at this point. With the impulsivity and the violence, we know that that's mediated in the prefrontal cortex, which is directly impacted by the use of methamphetamine, and particularly in impulse control and that stop function that we have that allows us to not eat a whole gallon of ice cream, but just have one scoop. That stop function gets impacted by methamphetamine as well. So it's easier for someone in the face of methamphetamine to be impulsive in that way, and that impulse may take the form of violence or acting out kinds of behavior. So we can pinpoint that in the brain now. We're just not at the point where we can do that for genes in a similar kind of way.
Yeah, okay. We will study about it more. Okay, and the last question to Dr. Enyawati, you mentioned about psychotic and methamphetamine. Is there any guideline to treat a psychotic symptom because of methamphetamine use? Do you have any guidance treatment?
Yeah, as we know also, for methamphetamine use disorder, there are no guidance that's pharmacological guidance for methamphetamine. It's very clear therapy pharmacology, but maybe in the few research also we have know about the naloxone, bupropion, or maybe an acetylcysteine also, but in methamphetamine use disorder with a psychotic disorder is can be treated maybe by symptomatic sign, maybe Dr. Sister, because for methamphetamine use disorder there are no pharmacotherapy that's very clear in evidence. I think that's all.
Yeah, and I also and we can also add antipsychotic, of course. And Thomas, can you add about that in your experience?
Yeah, my understanding is similar to Dr. Erniawati's, which is what we want to, because we don't have medicines that address that we know from a clearance and a research perspective work on these issues. What we want to do is symptom control. And so someone who's having severe psychotic symptoms, the recommendation is often that you use an antipsychotic medication to calm the whole system down and allow the person to return to more normal functioning. If they're having severe depression, considering the use of an antidepressant medicine is probably warranted, but the recognition that it's going to take 4 to 6 weeks for it to become clinically effective, they need to take it every day. So we may not consider that until we've got some time stable in recovery in order to then consider depression is ongoing. We know that giving them an antidepressant isn't going to treat the methamphetamine directly, but making them less depressed may hold them in treatment and therefore make them more amenable to the other services that we have. So symptom amelioration, I think, is what we look to medicines mostly to do in this particular case.
Yeah, so thank you, Thomas and Erniawati. So the last question is for Thomas. How about to prevent the relapse? How to prevent the relapse of from methamphetamine or amphetamine using?
Yeah, I don't think we do. I don't think we prevent the relapse. I think that we need to acknowledge that this is a very severe disorder and the symptoms of the disorder are going to express themselves. We would never say to someone who has depression, how are we going to have a non-depressed week, right? What we're going to do is we're going to watch for them and we're going to help them figure out, as you get more depressed, how are we going to help you? As you get less depressed, how are we going to help you so that over the course of time, you can have the best life possible. I think the same is true with substance use. We need to give the person the best treatment that we know we have. Contingency management combined with cognitive behavioral therapy, good exercise routine, and some mindfulness. That's what I would put together as a program for this particular condition. But there are many places in the world that as soon as this person uses, they're obviously a bad person and we kick them out. That is the absolute opposite of what we want to do. We want to see it more like depression so that we can say, look, they're having an exacerbation of their symptoms. We need to give them more care, not less care. And the secret to keeping them alive, the secret to them to not relapsing and relapsing less and less, the secret to them having a happy, healthy, productive life is bringing them into treatment again and again and again and again and again and again and again. I could go on for some time. The more times we can get their butt, excuse my language, in a chair, in an office, the better the predictor that they're going to do well in the long term. And so retention is key for everything, in my opinion.
Okay, so it's very important to have a longer retention for the patient, for the people with methamphetamine and amphetamine user. Okay, so there is one question more, and I think it's important. Wait a minute, please. So this is the last question, I think. Dr. Thomas, do you recommend the use of nicotine or tobacco products in the residential treatment program?
Use of nicotine?
Yeah, nicotine or tobacco products in the residential treatment program.
It depends on what we mean. If we're using nicotine products to help people stop smoking, it's probably the single best health intervention that we can do. If we're letting them go out to the yard and smoke because they have a nicotine habit, I think that's a bad decision mostly. There's research that shows that if we help people stop nicotine at the same time they're stopping other things, they actually do better in care than they do when they continue to smoke and we wait and we put that down the line. So I would say a good stop smoking anti-nicotine program as a component of their overall health care is really, really critical. And that may include nicotine replacement therapy.
Yeah. Thank you so much, and I also agree with that. Thank you so much, Thomas and Erniawati. So thanks again to both of you for answering those questions, and also for the great presentation. It was a pleasure to have you with us with the ISSUP International. And this concludes the webinar. We already learned about methamphetamine and amphetamine from the all aspect, the effect of the brain, physical symptoms, and also the characteristic of the drugs and also the treatment. And Thomas mentioned that it is very important to do the longer retention to the better outcome. And also we hope you learn something new and enjoy the presentation. You will receive the follow-up email within 24 until 48 hours with a link to view a recording of today's webinar. We always appreciate your feedback and suggestion. Please use the link in the follow-up email to fill out the feedback survey. On behalf of ISSUP and our presenter, thank you for joining us today and have a great rest of your day. Thank you, Thomas and Erniawati, and see you again. Thank you so much for the organizer.